Welcome. Today it is possible with the right treatment and using the right approach to reach the state in which children with asthma stay healthy and active in spite of their breathing problems. Today it is possible with the proper treatment provided at the right time to control your child's asthma so that they will not have an attack, no coughing, no wheezing, no shortness of breath, no phlegm, no symptoms at all. Today it is possible with proper and timely treatment immediately after the first signs of an asthma attack, usually cough, to overcome the attack within only a day or two. In order for you, the parents, to be able to achieve these goals, I would like in this presentation to provide you with the right tools to help you make the proper decisions. I will show you how to prevent asthma attacks, how to identify the first signs of an asthma attack, and how to manage the attacks by providing the proper treatment as soon as the attack starts. This discussion will include which drug to give, when to stop the drug, and when to seek medical attention. Some children have sensitive airways. In these children, when certain stimuli or substances from the environment enter the airways of the lungs, the airways, instead of looking like this, look like this. In reaction to the stimulus, the airway muscles contract, their walls expand, and thick mucus accumulates inside them. As the situation worsens, the airways get more and more blocked. The child finds it difficult to breathe, and we can see his chest rising and falling. The child's breath makes a whistling sound, like this. We also hear rhonchi, like this, caused by the air passing through a pathway filled with mucus. As more and more mucus accumulates in the airway, the child coughs in an effort to expel it. When coughing is no longer useful, the child starts to swallow the mucus together with saliva. The mucus then accumulates in his stomach, and eventually the child will vomit. Shortness of breath, wheezing, rhonchi, coughing, phlegm. All these occur almost simultaneously when an airway that was normal becomes abnormal. I will first explain where these airway passages are located and how they work. Then I will discuss the different triggers that can penetrate the airways from outside and cause them to become inflamed. This will be followed by an explanation of exactly what you should do when your child is having an attack in order to overcome it as soon as is easily possible. I will discuss what we can do to strengthen the airways in order to prevent attacks in the future, what we call prophylactic treatment. All people have two lungs, one on each side. During breathing, air enters the body through the mouth and nose. From there, it is conveyed through the trachea or windpipe and then to the bronchus, the major airway leading to the lungs. And this process is repeated about 23 times until we have a veritable tree. The first 15 such divisions yield almost 30,000 airways, and all of these are involved in the asthma attack I described. The branches continue to split until we get to the tiniest ones, the bronchioles. Each bronchiole is surrounded by 100 air spaces called alveoli, surrounded by a myriad of blood vessels called capillaries. Air containing oxygen enters from the mouth and nose, flows through the main airway, and all the way down to the alveoli. And from there, the oxygen enters the blood. In return, it carries the carbon dioxide back to the lungs, and from there it is exhaled. Bronchitis, bronchiolitis, spastic bronchitis, and asthma are all diseases of the airways. Pneumonia is a disease of the air spaces, the alveoli. If we correctly treat bronchitis, bronchiolitis, spastic bronchitis, and asthma, the illness will not progress to the alveoli and cause pneumonia. If we don't, pneumonia may develop. When your child comes down with a cold, you take him to the doctor, and only about 10% of the airways are blocked. So no doctor can yet hear any abnormal sounds from the lungs. The parent takes him back to the doctor the next day. By this time, some 20 to 30% of the lungs' airways are contracted. Only on the third or fourth day, when the airways are almost completely blocked, will the doctor begin to hear abnormal sounds. At this point, he says, I hear noise in the lungs, and I assume it is bronchitis and not pneumonia, because the noise is occurring on both sides. Nevertheless, I can't be sure one side isn't completely blocked. So to prevent possible pneumonia, I will prescribe antibiotics. After the first, second, and third prescription for antibiotics, the doctor realizes that the situation has gotten out of hand. So he sends the child for an X-ray of the lungs. On the X-ray, the radiologist sees a patchy white area on both sides of the lungs. Again, it looks like bronchitis. but he can't determine for sure if the child has pneumonia. Therefore, the radiologist will carefully describe the findings in the report to the child's doctor. The doctor reads the description of the findings and notes that there are signs in the lungs on the right side and on the left side. Again, this appears to be bronchitis, but again, he can't be 100% sure there's no pneumonia. So the doctor prescribes antibiotics, because although the child is in the majority of cases will not have pneumonia, there is a small risk that he does. It's not that your doctor doesn't know. I don't know either. No doctor can be sure. The person who must decide if your child is ill is you yourselves, the parents. You know your child better than anyone. The minute you notice that the child doesn't look well and is starting to cough, and you hear the same wheezing breaths as in the previous attack, you know that this is the onset of a new asthma attack, and you should start treating your child. At this early stage, the doctor usually can't help you. If you are able to recognize an attack in your child when the blockage is still 10 to 20%, enough of the airway is still open for the medication to penetrate, and within a day or two the attack will be over. If you wait 2 to 3 days, a good part of the airways will be blocked almost completely. The child will therefore need higher doses of medication, and the response will be slower, and sometimes we won't be able to stop the downhill road to pneumonia. You have to rely on your instincts. As soon as you feel your child is ill, start treating. The earlier you start, the better the outcome. Up to this point, we have gained a general understanding of where the illness occurs and what your job, the parent's job, is. Now I'd like to discuss these issues in greater depth. To explain the changes that cause the airways to deteriorate, studies conducted over the last decades have shown that asthma is an inflammatory disease of specific cells, the epithelial cells, situated in the innermost part of the breathing apparatus, that is, the lining or mucosa of the small airways. Children with asthma have particularly sensitive epithelial cells. During an attack, some stimulus or trigger from the outside penetrates the airways of the lungs and damages or destroys the sensitive respiratory epithelial cells. Substances contained within the cells spill out. We have several possible directions from which we can control the problem. We can try to control the steps leading to the transformation of these cells to sensitive cells. We can try to prevent the exposure of our child to the external triggers that enter into the airways and cause an attack. Once the stimulus has already penetrated the airways and caused an attack, we can help our child overcome it and recover from the attack quickly and easily. Finally, we can try to strengthen the walls of the airways, more specifically the membrane of the sensitive cells, in order to prevent their destruction, which then leads to an asthma attack. That is, we coat the sensitive cells in the lungs to prevent them against triggers in the environment. As I will explain later, this coating needs to be administered daily. Once is not enough. Each day new cells are created, and each day the new cells need to be coated. This is a long-term process until the body detects the defect and corrects it. Bronchial reactivity changes with age, and there are several mileposts along the time course of the disease that may signify exit points for different children. In a large proportion of very young children with a diagnosis of asthma, the symptoms are alleviated by age 2 to 3 years. We assume that these children probably did not have true asthma at all, but simply small airways that were easily blocked. As they grew, their bronchi enlarged. The external triggers no longer cause significant obstruction of the airways. Until age 3 years, we have to manage all children with suspected asthma alike, using the same medications, the same approach, because we can't know ahead of time which ones will be asthmatic at a later age and which ones won't. We do know, though, that if both parents were asthmatic, the likelihood is higher that their child is asthmatic as well. The next exit point from asthma is age 5 years, what was once called spastic bronchitis. The next age is 10 years, and the final one is adolescence. By adolescence, most children who ever had a diagnosis of asthma have recovered. Only in the most severe cases can the disease recur later. Thus, the disease usually passes with age, and this, at least, provides much room for optimism. The first option is to correct the sensitive cells the body is producing in the airways of the lungs. In some children, the cells are extremely sensitive, and the child is always ill. In others, they're mildly sensitive, so only certain triggers or triggers in large amounts set them off, while others or lesser triggers won't. These children are ill only occasionally. The human body contains mechanisms to find sensitive cells and try to fix them. If the defect to the cells is mild, the body will be able to identify it easily and will correct it rapidly, and the illness passes. If the defect is more severe, it takes the body longer to correct it. Even this child will ultimately recover. Our job is to help the child to pass the time until total recovery from asthma without suffering from asthma symptoms and with as few attacks as possible. What are the external triggers that can cause an attack? How can we protect our child from exposure to them? There are many triggers that can cause an asthma attack. I will break them down into 5 main groups: changes in the weather, viral illness, exposure to allergens, physical exertion, psychosomatic factors. Changes in the weather. Cold air that enters the lungs affects the airways and causes an asthma attack. Dry air that enters the lungs affects the airways and causes an asthma attack as well. What are ways we can prevent our child from breathing cold or dry air? Don't let your child run around outside on a cold day. This will cause the child to inhale lots of cold air, and he could have an attack. Don't let your child into a room overly chilled by air conditioning. Especially don't let your child go directly from the warm bath into an air-conditioned room. Don't take your child directly from the beach to a cold air-conditioned car. Certain means of heating may also be dangerous because they dry the air. Remember, it's not only cold air that's harmful, but dry air is harmful as well. Therefore, if your house is heated, you need to ensure that the air remains damp. You can do this by using a humidifier, placing damp towels over the radiator, leaving an electric kettle boiling with water, leaving a window open, or leaving the door to the bath open. Colds. The common cold is a very important trigger of asthma. Every infection of an asthmatic child with a cold virus will cause an asthma attack. Once the child comes down with a cold and has an asthma attack, from that point he will never have a cold without an attack. Therefore, you must exert the greatest efforts in preventing your child from catching a cold. How can this be done? If you take your 1.5-year-old child to a daycare center with 10 children, he will have a cold 10 times a year. There's never a time that at least 2 or 3 children don't have a cold. With the first sneeze, anyone within 4 meters catches a cold and comes home ill. The smaller the child, the smaller the airways, and the easier for the child to acquire an illness. Then the child is frequently ill. The older the child, when he starts kindergarten, the larger his airways, and he will be less frequently ill. It is important to make sure that your child does not go to the house of a friend who has a cold. If there's a sibling in the house with a cold, don't let him or her share a room with your young asthmatic child. Send one of them to the grandparent, if possible, or to another part of the house. Keep the child with a cold in a well-ventilated room so the viruses won't spread throughout the house. If your child wakes up with a cold, you have a problem. You must start to treat him immediately with the asthma drugs according to the protocol given to you by your doctor. 80 to 90% of asthma attacks in children under the age of 3 years are caused by the viruses of the common cold. Things get better as the child gets older, though the rate remains relatively high. We probably can't eliminate all colds. To do so would mean closing up the child in a hermetically sealed until he's ready for college. This obviously is not a good idea. Physical exertion. This probably relates more to older children. Intensive physical activity over time causes shortness of breath. The child runs around the school 2 times in gym class. By the 3rd round, he can't breathe. The child runs up 4 flights of stairs because he's late for class. By the 5th floor, he can't breathe. We want your child to be able to engage in normal physical activity. The child with asthma can participate in physical activities at school. If he wants to run the 2,000-meter course, he must take his bronchodilator medication before he starts running. If the child wants to run the 500-meter course, he should have his bronchodilator medication at hand. Older children with asthma may participate in school trips under 3 conditions. 1, they should have their bronchodilator inhaler handy at all times and know how to use it. 2, the trip guide and accompanying teacher should be aware that the child has asthma. And 3, the child and the guide should have a cell phone within reach at all times. Physical activity in cold, dry air is a very strong trigger of asthma attacks. Asthmatic children can swim in regular outdoor pools, but not in indoor pools which have lots of chlorine. All activities inside the gym are fine. Exposure to allergens. All kinds of substances in the environment can enter the airways and interact with the sensitive cells, causing an asthma attack. We have to try to keep our child from being exposed to these triggers. Some are found inside the house and others outside. The greatest danger inside the house is posed by bedding because sheets, covers, pillowcases, and mattresses all harbor dust mites. Dust mites are tiny insects invisible to the naked eye. If you magnify them 500 times, they look like lice or ants, meaning they're 500 times smaller than an ant. The feces or excrement of even a single mite that enters the airway can cause an asthma attack. Unfortunately, there is not a house or bed or a mattress in the world that is completely free of dust mites. We cannot eliminate them completely. All we can try to do is keep them to a bare minimum. How can we lower the presence of dust mites? Dust mites need humidity and organic environment to grow. For nutrition, they eat mold and the cells that fall from human skin. So it's a good idea to replace cotton and woolen bedding with synthetic materials that provide less suitable living conditions for the mites, to keep the bedding clean and dry at all times, and to consider the use of allergy encasements. This can significantly lower the risk of exposing the child to dust mite. Inside the house, attention should also be addressed to 2 more important factors. Don't smoke near an asthmatic child. Cigarette smoke can irritate or block the small airways. Once the diagnosis of asthma is established, don't bring cats or dogs into the house. After an already sensitive child spends, say, 50 to 60 hours in the company of the dog or cat, he will develop a sensitivity to the animal's hair. Every time he's close to a dog or a cat, he may have an asthma attack. Make sure the child avoids close contact with birds because of their feathers and any other animal with fur. That, I'm afraid, leaves the child with a choice of a Tamagotchi or computer games. Unfortunately, pets are a real problem. Within the house, substances with sharp smells such as paint and perfume are best avoided. Outside the house, children with asthma are affected by smoke from bonfires. Tree, grass, and weed pollens are major triggers. It's not wise for an asthmatic child to sit under trees when they're blooming and full of pollen. The pollen will penetrate his lungs and he will develop a sensitivity to it. How can we know what the child's sensitivities are? If we test a child younger than 3 years of age to inhalant allergens, the test results are usually negative. If we perform skin tests in an older child, we can only uncover sensitivity to those allergens tested. There still may be sensitivity to other allergens we have not included in our testing. The substances to which the child's skin reacts to may not be indicative of the sensitivity of his lungs. we would have to have the child inhale dozens of potential triggers and possibly cause him dozens of asthma attacks. In addition, intradermal skin testing may itself pose a risk in asthmatic children because high enough amounts of some of the allergens may induce a general allergic reaction in the body. The final factor I want to cover is emotional triggers. Anger, crying, laughter, irritability, all these can lead to an attack of shortness of breath. You, as parents, must try to prevent your child from unnecessary extreme anger, bouts of crying, and tantrums in order to avoid the risk of an attack. Now that we understand the external factors that can irritate the airways, there are two main protocols for treatment of asthma. Treatment given only during an attack, and treatment given to prevent an attack on a regular basis. The purpose of giving treatment only during an attack is to help the attack pass as easily and quickly as possible. This child can manage well with such as-needed treatment only. Preventative treatment is given to children who have asthma symptoms most of the time. The child who's not over one illness and already he's coming down with the next one. Prophylactic treatment is usually used more in winter. In the summer, we try to give treatment only as needed. Both types of drugs are used. The drug that opens the airways and the drugs that keep the airways open. The drugs that open the airways include Ventolin, Bricklin, and Oxys. They are easily recognized by the green or blue color of their devices. The drugs that keep the airways open include budesonide and fluticasone. Their inhalers are usually brown or orange. The drugs that open the airways offer symptomatic relief. That is, they are targeted against specific symptoms. For example, Acamol is a symptomatic drug against fever. Your child has a fever, you give him Acamol. The fever goes down. The fever rises again, you repeat the Acamol. The fever goes down, and so on. Similarly, during an asthma attack, Ventolin and Bricklin open the airways. This allows more air to get through so the body can recover from the attack itself. If we treat the child with severe illness only with the drugs that open the passages, then once the passages are open, the body begins to neutralize the drug. The effect wears off and the passages close up again. The whole process repeats itself. The body has two tools to control asthma attacks, but for more severe attacks, this can take 3, 7, or 14 days and can lead to complications. Therefore, to quickly and effectively stop asthma attacks, it's best to use a combination of drugs that open the airways, like Bricklin or Ventolin, and then keep them open with Budecort or Flixotide. This combined treatment may also prevent side effects due to the accumulation of Bricklin and Ventolin when administered over a long period of time. These adverse effects include hand tremors, rapid pulse, irritability, and others. If these drugs are given more intermittently, they don't accumulate in the body and consequently don't cause side effects. Immediately give your child Ventolin or Bricklin to open the airways. Right after that, administer Budecort or Flixotide. Thereafter, repeat the prophylactic treatment so the child gets it 4 times on the first day to 3 times a day, with dose adjustments accordingly, and so on for 4 to 6 days. This is the best way to stop attacks. You, the parents, should decide that an attack has started. You should provide the treatment. If within a few days you find the treatment is not successful, seek the advice of your doctor. After you explain exactly what the child received, the doctor will check that you have adhered properly to the schedule of drugs, including the frequency and administration. The doctor will also check for errors in technique of administration and proper functioning of the devices to administer the drugs. Prophylactic treatment is designed to prevent the asthma attacks from recurring. We give the child a drug that coats the cells situated in the airway walls in order to protect them from being stimulated by triggers. Until the body itself is able to deal with the problem, prophylactic treatment is analogous to an umbrella where the illness is the rain. If it rains once a month, you don't need an umbrella. If your child gets sick once a month or less, you need to treat him only during attacks. If it rains every single day and you don't use an umbrella, you'll get wet. This situation is impossible. So you take an umbrella. Hold the umbrella over your head all day. You won't feel even a drop of rain. Hold it only in the morning or once in a while. Chances are you're going to get wet at least some of the time. Hold it upside down, you'll get wet again. In the same way, the child who does not follow his schedule or uses his device incorrectly or forgets to take his medication will be sick. But the child who faithfully adheres to his schedule of treatment day in and day out and never forgets, the child who takes care of his inhaler device, uses it correctly, and ensures that all the medication gets into the lungs, will stay healthy. What prophylactic treatment do we have for asthma? At present, there are only two groups of drugs: singular tablets and inhaled corticosteroids, budesonide, beclomethasone, and fluticasone. Singular is a relatively new drug that has been on the market about 10 years. Singular is recommended for use by children with borderline to mild asthma. Mainly, though, it's used as an adjunct with other drugs. If, for example, we administer Budecort to the child and it doesn't seem to help or helps less than it should, adding Singular will aid the Budecort to enter the lungs and do its job more effectively. The other prophylactic drugs, budesonide, beclomethasone, and fluticasone, are corticosteroids. Corticosteroids are synthetic forms of cortisone, a hormone that is secreted naturally by the body by two small glands situated above the kidney, each the size of a fingernail. Cortisone is sometimes called the hormone of life. The body has a certain amount of natural cortisone. If we take oral drugs containing corticosteroids, such as betnazole, betapred, betnalan, prednisone, and danolone, we significantly increase the amount of cortisone that's already in the blood. Taken orally, systemic corticosteroids can cause immediate side effects, such as irritability, facial swelling, and changes in appetite. If we take corticosteroids in large amounts over a long time, it can have more severe side effects. Steroids that are inhaled have lesser side effects than those taken by the oral route. You need to press an inhaler holding 200 micrograms of Budecort 25 times to get the amount of cortisone contained in a single pill of prednisone. If he used a spacer, he would need to press twice on his inhaler. That would give him 2% of the 1/25th the amount of corticosteroid in one tablet. 98% of the drug is absorbed immediately by the lungs, and only 2% reaches the bloodstream by absorption through the mouth and the saliva, and enough to stop the attack. It is estimated that 1 year of treatment with inhaled corticosteroids is equivalent to the amount of steroid found in one 3 to 5 day treatment with oral steroids. I began to administer Budecort in 1983. Thousands of children have since used it. I treated a group of 2 to 5 year olds for 5 years. I found that the outcome was perfect, excellent protection with zero side effects. There were no problems whatsoever. The results of this trial were reported in a world-famous medical journal. I was invited to join international groups to set guidelines for the diagnosis and treatment of asthma on a global scale. The use of Budecort during attacks, however, is not accepted by everyone and not written in all textbooks. The recommendations I've outlined here are based on my own experience. My work over the last 30 years has shown that Budecort, delivered by an inhaler device during an asthma attack, can stop the attack in children. However, the drug must be used as directed. You need to carefully adhere to the instructions. One of the audience asks, how long should you give your child preventative treatment? The answer: this is like asking how long one should hold that fictitious umbrella. Well, until the rain stops altogether. We can't know when it's going to stop raining. We administer the medication for a while, say a month or two. If the child doesn't have an attack, great. We stop and see if he stays healthy. If he doesn't and has another attack, we open the umbrella again. We have no way of knowing the optimal time, No measurements, no tests, though your child will probably need less treatment in the summer and more in the winter. Children need to carefully learn the technique. To make it easier, you can use a spacer, which looks like this. For your young child, the metered dose inhaler and spacer are attached to a mask. This is difficult to use because you, the parent, need to hold the child down so that he doesn't move. Place the mask on his face and create a vacuum, and make sure that he inhales the drug. This requires a special skill that has to be learned. Asthma medication can be delivered by a metered dose inhaler. The metered dose inhaler is more difficult to use because the child has to coordinate the actuation of the device with his inhalation of the drug. The dry powder inhaler is set by pressing a lever like this, or a dry powder inhaler, which works like this. First, he has to remove all the air from his lungs. Then he inserts the inhaler into his mouth, inhales very deeply to draw in the air containing the drug, and hold it for a few seconds. The use of these devices requires a special skill that has to be learned. If used incorrectly, none of them will be effective. The last thing I'd like to talk about today is food and food allergies. Children with asthma can eat everything, even milk and peanuts. Milk does not cause mucus production. Some children, of course, may be allergic to cow's milk, and they should not have it. If they do, they will have symptoms of milk allergy. This may include vomiting, swelling, skin rash, and so on. Allergic children who are also asthmatic may have an asthma attack when they drink milk. Children who are not allergic to milk can drink as much milk as they want with no effect on their asthma. The same is true for peanuts. Asthmatic children can eat as much bamba as they want. In Israel, peanut allergies are rare because every newborn is met by a father or grandfather holding a bag of bamba the minute he's released from the hospital, and he continues to eat it the rest of his life. Thank you very much for coming.